All right. Well, thank you so much for having us, everyone. Here is the name of our talk and our conflicts of interest. We don't have any, but I will be discussing off-label prescribing of medications so everyone is aware. Here are our learning objectives. And I'm going to jump right in and start the talk with a conversation about weight-inclusive care. So this is a framework that is recommended by the Association for Size, Diversity, and Health. They are a nonprofit that educates medical practitioners about anti-fat bias and advocates for care that does not focus on weight loss. So this group has been very critical of the weight normative approach in traditional healthcare. They are concerned that traditional healthcare has caused people to have disordered eating, to experience weight cycling, and then even healthcare avoidance. And so I think that we have to take these criticisms very seriously. We know that people do experience anti-fat bias in the healthcare system, but we also know that living at a higher body weight can correlate with many health conditions that can be very serious for people. And many of these conditions are treated in primary care every day. And then more serious health conditions like cancer. So in my opinion, primary care doctors are really the best providers and the most knowledgeable and best equipped to discuss weight with their patients. So how can we reconcile these two concerns of helping care for our patients and improving their health while recognizing that this has been very challenging for patients when they try to access care? So first, we highly recommend something called the 5A's framework, which starts with asking permission. So the Health at Every Size movement recommends an informed consent model when discussing body weight. And so when you're concerned that a patient's health is being affected by their weight, you would start by asking them permission. Would it be okay if we discuss their weight today? And the patient may say no, and that's totally fine. And you could just move on and discuss the other reasons why they came into the office that day. If the person says yes, then that's your opportunity to move forward with the rest of the A's. So the next one would be to assess their story. How has weight affected their health and their life over the years? What things have they tried over the years to treat their weight? What has worked? What hasn't worked? And then move on to advising them on possible management options, which can include behavioral health strategies, lifestyle changes, medications, and bariatric surgery. The two of you would agree on the goals, and then the provider would assist the patient with addressing any barriers to care. A few other considerations when thinking about weight-inclusive care and how to implement this in your practice. We recommend creating a welcoming environment for patients of all sizes. I think the UW does a really good job of this. We have many chairs, throughout the hospitals and clinics that don't have armrests or are double-sized, blood pressure cuffs that are large enough, gowns that are large enough, bariatric hospital beds in all of the hospitals. So I think we're doing okay there. Some other considerations, I recommend really shifting the conversation from weight to health. We really think about weight as more of a cosmetic concern, and health is why you and the patient are in the office today, and how has weight affected their health. Other things to think about, you can absolutely make checking a weight optional or even a blind weight. So many patients, when they come in for their physicals, it's just standard that we would check a weight at the time of the physical. And if the patient declines, then that's really not a big deal, and you can just move forward and not worry about it. The Health at Every Size movement has been very critical of the BMI. This ratio or calculation really was never meant to be used as a diagnosis or way to diagnose when it was first formulated, but that is absolutely how it's being used nowadays. It's kind of baked into the healthcare system, if you will. Their concerns about BMI is that it can miscategorize people. So there could be individuals with very high muscle mass, but a lower waist circumference that are categorized as overweight or obese when they are actually at lower risk. The larger concern is individuals with a low BMI but an elevated waist circumference are at increased risk for cardiometabolic disease. So you could even make an argument to replace the BMI with a waist to height ratio. So that would involve checking a waist circumference and then dividing that by the person's height. And below 0.5 is considered low risk and above 0.5 is high risk. Something else to consider would be really to advocate for your patients when you notice other practitioners are limiting their care. So this can come up pretty frequently with surgeries, and particularly orthopedic surgeries. So in primary care, it's pretty common to see an individual with severe chronic knee pain due to osteoarthritis. And you refer that patient to orthopedics, they go and have a visit, and they're told, okay, you could have a knee replacement, but you need to lose some weight first. And then they're kind of just given this blanket recommendation, lose weight and come back when your BMI is lower. The orthopedic guidelines have actually been changing are related to this. So they're moving to a more informed consent model where, yes, an individual at a higher BMI may be at slightly higher risk of a post-op infection or complications related to the knee replacement. But as long as the individual understands those risks, and they could go forward with having a knee replacement. And then last, I'd like to just make sure everyone's aware of how much weight loss somebody can achieve with a healthy diet and regular exercise. On average, it's about 5 to 10% of their initial body weight, which is incredibly effective and helpful for managing chronic diseases like high blood pressure and diabetes. But often patients are hoping to lose more weight than that. And then when they are not, it can be very demotivating. They are putting in so much effort and really not seeing the results that they were hoping for. And so I think just managing those expectations can be really powerful. And so I think for all of us, just shifting this expectation that eating less and moving more is going to fix the problem when, unfortunately, that's not always the case when people are implementing lifestyle. All right, so I'll draw your attention to two U-Learns. One is called Weight Inclusive Care, if you're interested in learning more about this topic. And the next one is called Discussing Weight with Your Patients. So conversations about weight can be very challenging. Without the right tools to communicate, that can lead patients and clinicians to become disengaged and really negatively impact their relationship. So this U-Learn utilizes a motivational interviewing approach to support your patients and you in having effective conversations about weight. And last but not least, I would highly recommend removing the term morbidly obese from your problem lists. That phrase morbid really isn't necessary. And I know that just any diagnosis or term where you're using the word obese, it's going to be challenging for people to see that on their problem lists. But at this time, the best ICD-10 codes are Class 1, Class 2, and Class 3 obesity.
All right, so we wanted to share that we will be touching on the National Practice Guidelines for managing overweight and obesity. And these are the practice guidelines that were used to inform the internal UW Health Practice Guideline, which we'll be discussing throughout this talk today. So first, initial screening and assessment. All adults should be screened for overweight or obesity annually. And currently that best practice is using the BMI. We know that this has limitations, as Dr. Netkowicz said. So if patients have a BMI of 25 to 35, it's best practice to obtain at least one anthropometric measure, including waist circumference. DEXA could be used, but we know it's not accessible and can often be very expensive. So, just making sure that if a patient has a BMI of 25 to 35, we should be doing that anthropometric measure, and waist circumference is often the easiest to obtain. We know that waist circumference is a practical and good indicator of visceral fat. a high waist circumference measurement is associated with increased risk for adiposity-related complications. And we know that measuring waist circumference can help identify patients that may have been misclassified by BMI. So if you and your staff are not currently trained, it's very easy to get training on this. You could reach out to our staff and we could share with you our procedures, but get a simple measuring tape that you can order directly through UW Health and Materials Management, and a simple training could get you and your staff up to speed on this. So the ACE guidelines have a really excellent visual of the algorithm for diagnosing overweight and obesity, and this very clearly cascades down to the treatment approaches for each stage. When you're doing your assessments, it is best to assess potential contributing causes that could be exacerbating someone's weight, increase or challenges with losing weight. So how are medications playing a part? Are there medical conditions like hypothyroidism that are contributing? What about social determinants of health and their access to food and their access to quality food? So really seeing the whole picture before we move forward with a treatment recommendation. And for all patients with overweight and obesity, clinicians should assess for adiposity-related conditions, doing routine screenings for prediabetes or diabetes, hypertension, dyslipidemia, and MASLD would be really crucial as you have these conversations. Like Dr. Netkowicz said, often the reason we might have a concern about their weight is related to these conditions. And if we can shift the focus to the condition and managing the condition, that's often better received by the patient, and is a more valuable conversation for them to understand why, you want to help them make lifestyle changes. So we do know that this population can have an increased risk for disordered eating. So if you have concerns about someone's relationship with food, best practice is to screen for disordered eating in primary care, and that's called the SDE screen. This is a questionnaire available in MyChart and HealthLink, and happy to share that information with you if you want to use that in your practice. It can easily be sent via MyChart. If someone screens yes to 2 or more of these questions, they would have a concern for their relationship with food and a concern for disordered eating. It would not diagnose them with an eating disorder, but just tells us that we need to understand better their relationship with food. So you can send a consult to nutrition. We have an intuitive eating class that can support patients with this. You can also send a consult to psychology. And if someone does have an active eating disorder, there are many resources, including that consult to nutrition and psychology, as well as outpatient therapy and intensive outpatient hospitalization programs as well. So pre-intervention assessment, really, you have limited time to do this, but doing your best to see the whole picture. What are their nutrition and dietary patterns? What are their physical activity habits? Not just saying exercise, that is more intentional, but do they enjoy gardening? Do they enjoy, something else that might not be termed exercise, but they're still moving their body in a way that helps their health and they're less sedentary? What are their social determinants of health, and what are their previous weight loss attempts, and leaning into their successes? If they've tracked their food before, maybe start there. If they enjoy walking, start there. That can usually help them gain confidence, and then they can move forward with a better step in that direction. And establishing those goals. Maybe for them it's weight loss. Maybe for them it's improved blood sugar control, improved lipids, improved hypertension or blood pressure. So really understanding their goals, and maybe weight is secondary to their other health goals. So when patients are ready to discuss weight loss interventions, clinicians should share how even small changes to weight can lead to significant improvement. A 5 to 7% weight loss improves their blood sugar, blood pressure, lipids, and more. And a 7 to 15% weight loss can reduce the incidence of nephropathy, obstructive sleep apnea, and depression. So really those small changes that Dr. Netkowicz mentioned, maybe that's not what they're hoping for, but it will lead to a positive impact in their health. And so just reiterating that small changes in their lifestyle and their weight can positively impact their health, even if it's not that number on the scale that they're hoping for. So the ACE guidelines, again, review the suggested therapies for each disease state. And as you can see, lifestyle is listed first for each of them. Weight loss medications may be recommended, and you may consider bariatric surgery, but lifestyle should always be the foundation of what we're talking about with patients. So what does that look like? A structured lifestyle intervention is designed for weight loss at least 5%, should consist of a healthy meal plan, physical activity, and behavioral interventions that we're going to dive into. So structured lifestyle interventions, a high intensity program is at least 6 months in duration, has at least 12 to 14 sessions over 6 to 12 months. And this also meets the guidelines for cardiovascular disease as well. So you may be wanting someone to improve their weight, but also it meets other guidelines. And so if you're interested in having your patient get in touch with a high intensity lifestyle change program, you can enter a consult to Lifestyle Medicine Nutrition, or you can share with them information about the program using the system-wide smart phrase .lifestyle change program. So a little bit about the program. We are a CDC recognized diabetes prevention program. There are 3 goals in the program. The first is to lose at least 5% of their weight. The second is to be active at least 150 minutes per week at a moderate intensity where they can talk but not sing. And the third is to lower their A1C by 0.2%. We have many enhancements for the UW Health Lifestyle Change Program that you might not see with other lifestyle change programs in the area. Our program offers a 12-month complimentary Dane County YMCA membership to all participants. And there are also opportunities to get one-on-one support with a lifestyle medicine specialist. All of our coaches are dietitians, so they will not be getting advice from someone who's not educated in nutrition. They'll be really well supported with nutrition and other lifestyle habits. We offer bonus classes on gaps that we see in the curriculum that we're required to follow. So we'll do like a meal planning bonus class. And we also offer a support group. So we started a Walk with a Coach support group that's also complimentary to all participants. So this is the standardized curriculum that we're required to follow, and you'll see the cadence on the far right. So we do meet weekly for the first 12 weeks, bi-weekly for 1 month, and then monthly for the last 8 months of the program. And we cover all things related to lifestyle. We talk about getting active and tracking their activity, eating well and tracking their food, how to get more active and maintain that moderate intensity activity, how to incorporate strength training, which is really crucial when someone is on a weight loss medication, maintaining their muscle mass. We talk about eating to support your health goals and that relationship with food, how to manage triggers when you're in the grocery store, checkout line, and all your favorite foods are sitting right there. How to take charge of your thoughts and work against black and white, all or nothing thinking, saying, if I don't go to the gym every day, I'm not successful. If I don't eat a salad every day, I'm not successful. We work away from that all or nothing thinking. How to get back on track, get the right support, how to stay motivated, how to work through weight loss plateaus when weight loss stalls, how to shop and cook and put that nutrition knowledge into practice, how to get enough sleep and manage stress. We know if we're not doing those 2 things, it's really hard to be successful with lifestyle. And then how to maintain these healthy habits for life. So a really comprehensive program. It's a group setting, learning from each other, similar challenges, and just supporting each other with lifestyle over the course of a year. So after you send that referral to Lifestyle Medicine Nutrition, we do pre-program screening for mental health, relationship with food, and access to food. If they screen positive, we make sure they have the right support to be successful in the program and make sure that that's not a barrier. And then we do offer the program. At least 50% of our classes are virtual, but we do offer in-person classes across Madison. And again, we have those 2 one-on-one supports throughout the program to help navigate any individualized concerns that maybe we're not addressing in the program. And we also just this week did get approved for an asynchronous curriculum. So in the future, we'll be able to offer the program on demand for patients that are shift workers, have families, just need access to the program, but can't attend a live class. So look forward to that in 2027. You're like, okay, this sounds great, but who's eligible? Anyone that's an adult with a BMI of over 25, if someone's Asian American, they can have a BMI of above 23. They cannot have a history of type 1 or type 2 diabetes. And for those on Medicare, they cannot have end-stage renal disease. They can also not be currently pregnant, but if they become pregnant in the program, you and I can work together to make sure that the program is supporting them having a healthy weight gain in pregnancy. We would no longer encourage them to lose weight, but just have a healthy weight gain. They do need to have a risk of diabetes, and that could be an A1C, a fasting glucose that's elevated, history of gestational diabetes, or for patients with commercial insurance, they can take the prediabetes risk test, and many patients are eligible with that. So after you refer them to the program, we help navigate that eligibility criteria. So maybe someone doesn't want to do a group class. They just want to focus on nutrition. We know that an energy deficit is required, and best evidence does show that there's actually no one size fits all diet or eating pattern, and no one diet has been shown to be superior to manage overweight and obesity than another. So simply the diet pattern that they're able to follow is the best diet. When you stop a diet, the diet stops working, just like when you stop a med, the med stops working. So it needs to be a lifestyle change that they can do long term. And we also should consider social determinants of health. So if you would like your patients to get more support with nutrition, we have the consult to nutrition for individualized medical nutrition therapy by a registered dietitian. And there's many health facts for you that can support your patients to get started, whether it's the plate method, healthy snacks, using the nutrition facts label. There's a lot of really easy to use information for them to get started with building balanced meals and nourishing their body. When it comes to physical activity, evidence does not support any one mode of physical activity or exercise being superior for weight loss or prevention of weight gain. The most important thing is for them to be active at least 150 minutes per week at that moderate intensity where they can talk but not sing. If they're walking the dog and the dog stops at every tree, might not be moderate intensity. So maybe they should walk the dog, drop the dog off, and keep going for their walk if that's what they prefer. But also strength training 2 to 3 times a week, especially if they're going to start a weight loss medication. We need to maintain their muscle mass. So if patients need support with this, you can do a consult to preventive cardiology or a consult to integrative health and wellness to help them, get some more support with getting active if that's new for them. If they have joint pain, we need to make sure we're doing this in a way that works for them. And then behavioral strategies. So there's many options that you can choose. Again, your time is often limited with patients. Goal setting is one of the most powerful. Having them do a SMART goal that they know they can achieve. I know I can drink 1 more bottle of water per day. I know I can go for a walk after dinner. Do what they are confident in doing. And when they succeed, they're going to build their confidence to be able to do more in the future. But these lofty goals often don't work. Self-monitoring. Patients that track their food lose twice as much weight as patients who don't. So that can be really helpful. Does not have to be MyFitnessPal or another app. It could be taking a picture of their plate, or it could be writing it down in a journal. But we know that is really effective. So if you need more support with that, consult to behavioral health, lifestyle medicine, nutrition, or again, integrative health and wellness would be great supports for your patients. So with lifestyle, we know that pharmacotherapy should always be used as an adjunct to lifestyle therapy. Evidence shows that the patients who start lifestyle at least 12 weeks before a medication have the greatest outcomes. And the medications were studied with lifestyle as the foundation that's in the package inserts. So, I'm very passionate about lifestyle, but making sure we're doing our best for patients and that they have the right foundation to be successful. If they do need to start pharmacotherapy, lifestyle should always be first. With that, I'll pass it off to Dr. Netkowicz.
All right. So some of the reasons why you would want to intensify therapy for weight management. Your patient has been implementing the lifestyle changes you guys agreed upon, and they're not really losing any weight. You would consider adding a medication or maybe even moving to surgery. Or if the patient did lose some weight, but now they are experiencing weight regain despite these efforts. And then finally, if a person has just more serious health conditions like coronary artery disease, uncontrolled diabetes, yeah, you would absolutely want to be more aggressive in managing those conditions. Next slide. So one of the options available to you is to refer to the Medical and Surgical Weight Management Clinic. We're located at East Madison Hospital, and I will just highlight some of the really awesome support staff that we have available. We have registered dietitians that work with all of our patients that are moving through the medical and surgical programs. And then we also have health psychologists. So on the surgical side, this is a requirement to have bariatric surgery, that they work with a psychologist. On the medical side, it's optional. So if we have concerns that a person is suffering from some type of disordered eating and we want them to have further evaluation, I would refer them to health psych. We also have a certified personal trainer who can help guide people on how to get started with exercise, because many people have never really engaged in that type of activity before. All right, so here are the more intense treatment options that you could consider, including medications and bariatric surgery. These are in the order of how effective they can be for weight loss on average. And I'll just point out that bariatric surgery is still the strongest way to manage weight. At 1 year, people can lose up to 30 to 35% of their body weight. Unfortunately, some people do experience weight regain after bariatric surgery. It's usually not all the way up to their pre-op weight, but that is often a concern when people are considering surgery. At 5 years, the weight loss from bariatric surgery looks pretty similar to what people can get from semaglutide injection and tirzepatide injection. The difference is the person had a laparoscopic abdominal surgery or they took a medication for 5 years. All right, we'll move on to the medications, and I'm going to go through these fairly quickly because I know that you guys have a ton of experience prescribing these already. So I'll just highlight a couple of different things about each med. So the first one is Contrave. This is a combo medication of naltrexone and bupropion. I have the brand name dosing listed for you, and then also you can replicate this medication by prescribing bupropion and naltrexone separately. But if you do that, that is considered off-label prescribing, and you would just want to let the patient know that is the case. When you're prescribing this medication, you would want to monitor their kidney function and liver function, and then also monitor them for worsening mental health conditions. And the bupropion can increase blood pressure and heart rate, so you would advise them to just keep an eye on that as well. All right, the next one is phentermine monotherapy. So this is an interesting medication because it is only FDA approved for 12 weeks of treatment. And that is because it was FDA approved back in 1959. And I think that's really reflective of how people thought about body weight in the mid-20th century as not necessarily a chronic condition that is potentially lifelong, which we know that is the case now. So there's the dosing that's available. You should check an EKG prior to starting phentermine, and this is recommended by the Wisconsin Medical Board. And then last, if you can continue phentermine long-term, even though it's FDA approved only for 12 weeks, that is considered off-label prescribing. But if the patient is doing well, they've lost weight with this med, they have no major problems or side effects, and they haven't developed a new contraindication, then it is reasonable to prescribe this long-term. This agent is similar to other stimulants like Adderall and Ritalin, which we prescribe to patients with ADHD for years, if not decades. All right, so the next one is Qsymia. This is a combo medication of phentermine and topiramate. And the brand name Qsymia is subject to a risk evaluation and mitigation strategy, kind of similar to Accutane. So it's only available through certified pharmacies. And that's because topiramate is a teratogen. You do want to check that EKG I mentioned, similar to phentermine alone. And then for the topiramate, it's just not recommended to combine it with metformin because it can increase the risk of lactic acidosis. All right, so this is the brand new kid on the block, orforglipron, under the brand name Foundeo. It's been FDA approved for weight management. I have the dosing listed for you, and you would want to monitor kidney function, liver function, and a cholesterol panel when prescribing this agent. This is an oral non-peptide GLP-1 that is metabolized by the liver. So unfortunately, it's a little bit pharmacologically messy, if you will. It interacts with the CYP system and can affect the dosing of other medications. The most relevant is simvastatin. And so if a patient is taking orforglipron and simvastatin, they can only take a 20 milligram dose of simvastatin. This one is semaglutide under the brand name Ozempic and Wegovy. I know you guys prescribe this agent a lot. The two big things to be aware of is that Wegovy injection, now the max dose is 7.2 milligrams, which is a big jump from the 2.4 milligrams that was previously the max dose. And then there's also now a Wegovy tablet, and this is an oral semaglutide, and it's a bit touchy as far as absorption. So patients need to take this first thing when they wake up with only 4 ounces of water, no other medication, supplements, food for at least 30 minutes. And you would want to monitor their kidney function, cholesterol, and blood sugar. All right, last but not least is tirzepatide, brand name Mounjaro and Zepbound. One of the nice things about this agent is the dosing is the same between the two brands, and then similar monitoring for the other GLP-1s. So a note on medication adjustments for kidney disease and liver disease. So if you have an individual that has moderate kidney disease or moderate liver disease, both Contrave and Qsymia need to have a reduced dose. And then if they have severe kidney disease with a GFR less than 30 or severe liver disease, cirrhosis, then both Contrave and Qsymia are contraindicated. And I mentioned that orforglipron is metabolized by the liver. So if somebody has severe liver disease, orforglipron is also contraindicated, and that's different than the other GLP-1s. And so update on pregnancy and lactation. So you can absolutely help manage patients for weight loss that could become pregnant or maybe are planning to become pregnant in a few years. And you can prescribe a medication, or they can even have bariatric surgery prior to pregnancy. For the medications, you would just advise the person that they need to stop the weight loss medication at least 2 months before a planned pregnancy, because no weight loss medications are recommended during pregnancy and lactation. And then if they are interested in bariatric surgery, that is an option, but they would need to wait at least 12 months before pursuing a pregnancy once they have surgery. And topiramate is a teratogen, as I had mentioned earlier. It can actually cause cleft lip and cleft palate. So if you're prescribing the Qsymia mimic, so phentermine and topiramate are separate, it is not monitored the same way. And so it's on you to update patients or make sure that they are informed about the risks to an unintended pregnancy and make sure that they're using an effective form of birth control. For both tirzepatide and orforglipron, the package inserts note that these meds can affect the absorption of oral contraception. So if a person is specifically for tirzepatide, they can continue their oral contraception, and they just need to use a backup method while they're starting the med and with dose escalations. And then once they're on a maintenance dose, the oral contraception is thought to work normally. For the orforglipron, it has not been studied for this issue. So in the package insert, they just advise to tell patients to use a backup method, or you could certainly consider switching them to a different form of birth control that is not oral. I'd like to highlight a diagnosis that is associated with obesity. It's called lipedema, and this is actually really fairly common. It can affect about 10% of the female population, where people will experience a bilateral, symmetric, disproportionate fat accumulation in their limbs. It's characterized by pain and easy bruising, and it spares their hands and feet. So they can even have this cuffing effect at the wrists and ankles where the excess fat just stops. It's very resistant to actually all weight loss treatment, but particularly exercise and diet for weight loss are not very effective. And it's often misdiagnosed, and where people are thought to have common obesity or even lymphedema. What's challenging is a person can have all three, common obesity, lipedema, that then goes on and causes the lymphedema. And here are the just types of lipedema that you can see in individuals. Primarily, it affects the legs, but it can affect the arms. And then there are the 4 different stages as the condition progresses. And the conservative treatment options include compressive therapy, manual lymphatic drainage with occupational therapy, exercise, but this needs to be low impact exercise or even getting into a pool to offload some of the forces on the person's joints. And the ketogenic diet has been shown to be effective for improving lipedema. If the person has been trying conservative therapy for at least 6 months and it's not working, the next step is actually liposuction. And as far as I'm aware, this is not available within the UW plastic surgery group, but there is a lipedema specialist in Chicago. And if this would be covered under insurance is anyone's guess, really. All right, I'm going to give you guys some helpful tips on prescribing, particularly GLP-1s. I know many patients are coming into your clinics or sending you my charts asking for these. So I highly recommend using the FDA-approved diagnosis with the correct brand name. So if you're treating moderate to severe sleep apnea, you would send the brand name of Zepbound. The only caveat to that is there are some GHC plans and Quartz 1 plans that actually cover Mounjaro for moderate to severe sleep apnea. And the only way that you would be able to figure that out is to try and send the medication or have the pharmacy team do a price check. When you are starting a person on a GLP-1, I recommend just sending one product with one dose. Often the clinical pharmacy team for weight management will pend the first 3 months with the dose increasing each time. Unfortunately, that bogs down the prior auth process because they have to get rid of all those extra doses and try to work on the prior auth. And most insurances will approve the medication for all doses, so you don't need to send all of the doses right away for the prior auth. You may have patients that are contacting you that have been waiting for several weeks for the prior auth. They haven't heard anything, and you go in and look in their chart, and you may see under the prior auth section in the medication that it says closed. That does not mean that it's complete. So if you're concerned that a patient has been missed somehow within the prior auth department, I recommend contacting them directly by sending an in-basket message. The last thing you want to do is actually resubmit the prior auth, because when you do that, that actually puts the patient at the back of the line. And then if you have a patient that you think a GLP-1 would be very helpful for them, and they have one of the FDA-approved diagnoses, I highly recommend just trying to appeal that denial. These different conditions have the best evidence that a GLP-1 would be very effective. And so I know that your time is short, but putting together an appeal letter, and then you can send that to the prior auth team to then submit to insurance. Unfortunately, many commercial insurances still are not covering GLP-1s, even for more severe conditions like cardiovascular disease. So if you have a patient that does have more resources or more means available, then you can certainly prescribe the medication direct to consumer through Lilly Direct or some of these other pharmacies. And they can use HSA or FSA money to cover those costs if that's something that's part of their plan. You all have likely had patients asking you about compounded GLP-1. This has been a huge issue for the last several years. The FDA has been attempting to get compounding pharmacies to stop this practice, and with pretty limited success. Their newest strategy, or the thing they're going to try next, is to remove liraglutide, tirzepatide, and semaglutide from the bulk list, so it won't be available for these pharmacies to compound. There is currently no UW policy regarding prescribing a compounded medication, so that is within your practice if you're already doing that or considering that for a patient. It's just a little bit more legally risky for you to do to prescribe an agent that way. All right, next slide. So some information about metabolic and bariatric surgery. I put in the metabolic and bariatric surgery risk calculator for you guys to check out. So this calculator, you could put in the person's height and weight and age and other various health conditions they might have, and then see how the various bariatric surgeries can affect their overall weight and how many of their health conditions can improve significantly. The two main procedures that are available within the weight management clinic are sleeve gastrectomy and a Roux-en-Y gastric bypass. You may have patients asking you about the lap band, and that has really fallen out of favor. It's been replaced by the sleeve gastrectomy, and it's not available within UW. A procedure that one can have after gastric bypass is called a transoral outlet reduction. So if a person has had a gastric bypass, many years have gone by, and now they're not experiencing the same type of restriction, it's possible that the outlet from the stomach pouch has gotten larger over time. And so the GI specialist can do an endoscopic procedure where they would make that outlet smaller again. I've put in a few of the contraindications to bariatric surgery for you guys to be aware of, because many patients, they may benefit from surgery or have a qualifying BMI, but they have frailty or some other serious health condition that would just make them not a great surgical candidate. Here is just some of the labs and things to be thinking about after bariatric surgery. So you may have patients in your panel that had bariatric surgery decades ago in another health system. You still want to be checking these labs, ideally once a year, but at least every couple of years, just to make sure that they are not developing a nutritional deficiency from the surgery that they've had. I mentioned, unfortunately, some patients can have weight regain after surgery. So you would review their diet and exercise habits and see how they're doing there. Is there anything they could improve? And it is totally reasonable to add a GLP-1 or other anti-obesity medication after bariatric surgery, because often these patients just have had just a less than ideal response to the surgery. And then I mentioned the TOR procedure that you could place a referral for. All right, so how low do you go? GLP-1s in particular can be very powerful for weight loss, and they can be so powerful that we actually are pushing the person's BMI too low or even causing a nutritional deficiency. And so there has been just a lot of debate over the years about what is the healthiest BMI or the lowest risk BMI for all-cause mortality. This debate started with a researcher in the early 2000s at the CDC by the name of Catherine Flegel. She plotted all-cause mortality versus BMI and found this J-shaped curve, where in her curves, the lowest mortality risk was actually at the overweight category, and there wasn't really much increased risk at class 1 obesity. But mortality risk does increase at very low BMIs and then increases as the BMI continues to go up. I liked these curves from a study that was published in The Lancet in 2018, because in this particular graph at the bottom, they have separated it out by age group. And this bottom line is, the green line is for individuals over 80. They actually tend to do better at a more overweight or maybe class 1 obesity. So weight can be somewhat protective. So if you have a person who is over 65, then you definitely don't need to push their BMI into the quote normal range. I think if they get into class 1 obesity or overweight, that's totally reasonable. If you have a person under 65 and they're doing well and their BMI gets down into the range of 22 to 24, that is okay. You definitely don't want to go into the low 20s or teens for their BMI, because again, that just risk of complications and all-cause mortality goes back up, and it's not necessary.
Okay, so this is a lot of information and kind of hard sometimes to put it all together. So I did want to let everyone know that the guidelines for management of overweight and obesity at UW Health is in Agile MD. It walks you through the guidelines very, very clearly, step by step, what you should do. So if you're at all just wanting to remember what we talked about today, refer to Agile MD and it walks you through the guidelines really, really nicely. And just a plug that tomorrow we're meeting to hopefully finalize health facts for you for GLP-1s. It should be HIFI number 8318. And this goes through everything related to GLP-1s. So it talks about how to personalize advice and support, including fiber recommendations, water, protein. It's not as high as some people might think on the internet. And also calories. We just simply need a calorie deficit. We should never be going less than 1,200 for any patient. And if you think so, then send them to nutrition and we can talk through that. But physical activity also goes through, the aerobic and strength training and how to manage symptoms. So for patients that are on these medications, there will be health facts for you soon on that. And I'll send it back to Dr. Netkowicz to wrap us up.
All right, take-home points. So unfortunately, the environment, and particularly the food environment in the United States, tends to cause weight gain. So any positive change that you can help people make in decreasing their consumption of highly palatable, energy-dense food is going to improve their health. We know that healthy lifestyle is absolutely the foundation of weight management, but it's incredibly challenging for patients to follow all these recommendations. Many people are time crunched. They may not live in safe neighborhoods where they feel comfortable going out for a walk, or have money to join a gym, or mobility to engage in exercise, or ability to cook in their home. So a lot of people need extra support to learn about healthy diet and just ways to pivot to be able to engage in some type of exercise, and maybe even medications and surgery to meet their goals and improve their health. There are a lot of different referrals available to support you and your patients in managing weight. So we've been talking about a lot of them: lifestyle med, referral to nutrition. There's also the clinical pharmacy team for weight management, and then also referral to a comprehensive weight management clinic. We know that insurance coverage for both GLP-1s and bariatric surgery, it's pretty spotty and it's difficult to navigate. So if you have a patient with some means, you could absolutely just do the direct-to-consumer option for GLP-1, or even consider an older anti-obesity medication. The GLP-1 meds will not come off patent until the mid-2030s, so we still have some time to wait for this to really improve as far as coverage. And then if you have a patient with one of those other FDA approved diagnoses, like moderate to severe sleep apnea or cardiovascular disease, then I highly recommend writing an appeal letter to try and get the med approved. And then last thing to be aware of, or a couple more things, the Medicare Bridge program is starting. So the federal government is interested in improving coverage for GLP-1s for Medicare beneficiaries. So you can check out the CMS website about this program that is starting July 1st, and it's going to run through December of 2027. And it's going to open up coverage for GLP-1 for a lot of people that have not had coverage for a GLP-1 so far. And then if you do have a patient that meets the medical criteria for bariatric surgery, so they're healthy enough to have surgery, and if they have a BMI over 40, they generally qualify, or if they have a BMI 35 and higher with at least one weight-related condition, then you should discuss this option with their patients, because it can really improve their overall health and ability to move their body and become more functional. So thank you so much for your time.